We're going to go ahead and start. Thank you for braving the rain and coming on out. I'm Kevin Kopis, and I'm the Executive Director for the Epilepsy Foundation Washington. Welcome to day one of November. November is Epilepsy Awareness Month. And so we hold this conference every year in the month of November in honor of Epilepsy Awareness Month. I think this is like our 32nd-ish year of holding this conference, believe it or not. And I think it started like in a high school years ago, and we have just kept it going. And it's really special for me because I grew up with epilepsy, and my parents didn't have anything. No resources available for them, and especially no conferences like this. And my mom, was always searching for information. Of course, this was like pre-internet. So, she was desperate to learn more. And stuff like this would have been so valuable for her. So it's always, nice that we're able to bring this to you. And you may have seen the agenda. Hopefully you've all got it. You may have seen there's some notes, like a note section on the back. So that's available. And then when the speakers are done, we will take some questions. This is an intimate enough audience that we've got some like floating mics that we'll kind of pass around to people. And so feel free to ask your questions to them. And then, fortunately, we're not competing against a football game today, so hopefully there's no traffic kind of coming in and out. It should be an easy day. I do want to recognize a couple sponsors here that if I go to this slide. These are the folks that have made this event possible for us. So they all have tables out there in the back, and a lot of them I've known for several years. And you would think that some of these people have personal connections to epilepsy, the way they're so passionate about supporting other people and families that deal with it. So please, during the break and as we'll take a lunch break, please go interact with them and say hi to them, and I'm sure they will be there to help you. And then the next slide I wanted to point out, because I wouldn't be an executive director if I didn't, and is the fundraising events we have. The gala is March 7th this year. If you've ever been, it's an exceptionally fun event. It's a great awareness event for the community to come together, and it raises all of the money for, it's still going, it raises the money for this. Perfect timing. This is a camp. And yeah, we pay for the whole camp for the kids the entire time. So that's what the gala and the walk, which is just down the street at Magnuson Park every year, raise the money for that camp. So please consider that, of course. And then finally, I don't know if we have any school nurses here today. Oh, we do. I tried to get a hold of Lisa Huggins, and I couldn't reach her. So I know she normally is here kind of signing off for clock hours and stuff, so I assume you know how to reach out to Lisa. I'm also willing to vouch, for your attendance here, if I can help. All presentations are being recorded, so they will be placed on our YouTube page. If you just search Epilepsy Foundation Washington in YouTube, all of the, I think we have presentations going back like 10 plus years. So we will post all of these. Give me a week or so to get those up there. But if you know people that wanted to be here and couldn't be here, they will be available for them. And with that, I'm going to turn things over to our first speaker, which is Dr. Lindsey Morgan. And Dr. Morgan is a clinician, teacher interested in brain-directed care in critically ill patients and the recognition of the impact of neurologic injury on short and long-term outcomes. She practices a pediatric neuro ICU and epilepsy physician with additional training in quality improvement. Further, she has traveled to rural Alaska several times a year to provide general neurology outreach care. She aims to utilize her knowledge to decrease disparities and improve the care of children with acute neurological conditions, with a particular emphasis on the hospital onset status epilepticus and sudden unexpected death in epilepsy. And I might add that she also served on the medical team this year for Camp Discovery. So please welcome Lindsey.
So thank you so much, Kevin, for inviting me to talk today. I am really passionate about outpatient onset of seizure emergencies. And so I'm hopeful that at the end of this talk, you'll feel a little bit more comfortable with managing those and ways to kind of help your children or loved ones get the care that they need in a quick time frame. So at the end, hopefully you'll be familiar with some of our seizure emergency definitions, be familiar with recommendations on treatments, and recognize some areas that we can continue to improve in. I have no disclosures. So I wanted to start with just a few slides on definitions so we're all on the same page. So what is a seizure? I probably don't have to tell you guys, but just for completeness sake, it's a transient occurrence of signs and symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. It is a very clear onset and offset, demarcated in time. And depending on where in the brain your abnormal electrical activity is happening, it depends on then what it looks like clinically. So it might be an alteration in awareness, you might have some motor activity, you might have some sensory symptoms, or even autonomic symptoms like vomiting. And seizures are really common, right? They, since this is focused on seizure emergencies, it's 1% of all visits to an emergency department are for seizures across all age groups. And it is highest, though, in the 1 to 5 year age group and the 41 to 50 year age group. And of those 1% of visits, 6 to 7% have status epilepticus that we'll define on the next slide. And the mortality rate can be pretty significant if your seizure is going for a prolonged period of time. And even without that mortality rate, we can have short and long-term neurologic morbidities with prolonged seizures. And status epilepticus, we define differently based on both the different time points as well as the different types of seizures. So time point 1 is when the mechanisms that typically stop a seizure have failed to work. And so it leads to a prolonged seizure. And so for people who are having these big convulsive seizures, that's defined as just 5 minutes. For people who are having a focal seizure, one side of the brain is active with seizure and they have a loss of awareness and impaired consciousness, we define that time point 1 as 10 minutes. And then for people who are having absence, behavioral arrest seizures, it's a little bit longer. Time 2 is when you have the risk for long-term consequences. So you have a risk for brain cell injury or death, and that is if your seizure is going on longer than 30 minutes for that big shaking seizure, or over 60 minutes for your focal seizures. And we don't know how long you have to have absence seizures to have that risk of neuronal injury. And this is just a pretty picture of an EEG for someone who's having an absence seizure. But there's also seizure clusters or acute repetitive seizures, which is also a seizure emergency. And that one's a little bit harder to define. There isn't a single definition, and it's really individualized based on the patient and what their kind of typical seizure pattern is. And so we tend to use the definition that was used way back in the late 90s when diastat was first being studied, and they defined it in that study as an intermittent stereotypic episodes of frequent seizure activity, so seizure clusters. They use the definition they use the term in the definition, that are distinct from a patient's usual seizure pattern. So for someone who has Dravet syndrome and they're having hundreds of seizures a day, their seizure cluster emergency might be having 5 seizures in a 15-minute period. Whereas someone who has a seizure once or twice a year, their seizure cluster might be defined as 2 seizures in a 24-hour period. So again, it's really dependent on the person. And so, why are we talking about this, and what is actually happening at the cellular level? And this is my one basic science slide, and I'm sorry, I can't do a talk without it. But when you have kind of your cell and your synapse here in your neuron, before status, you have all of your kind of excitatory and inhibitory little dots in the presynapse. And then as your seizure is starting, your GABA, the red dots, which are usually your inhibitory neurotransmitters, they're all released, but their receptors that they act on, those little blue triangles, they're down-regulated. There's less of them. So the inhibitory signal has nothing to connect to. So it's just hanging out, so it's not inhibiting the postsynaptic neuron. And you have a release of your white little dots, your glutamate, which is excitatory, and you have an upregulation of those receptors. So you have more excitatory action happening, less inhibitory action happening, and so you have an ongoing electrical signal happening. And so then what do we do about it? So there's rescue treatment. And our national guidelines recommend that we first stabilize a patient in just the first 5 minutes. And this is really for your convulsive seizures. And stabilization includes things like making sure someone is breathing okay, if emergency services is there, checking their glucose to make sure that's not a cause for seizures, and making sure that their heart rhythm is okay. But really quickly afterwards, within the first 5 minutes, we recommend treatment. And that treatment can be, should be with a benzodiazepine. And we'll talk about the different options, but you can see here, our national guidelines, they just say, give one of these 3 equivalents, and it can be intravenous or intramuscular, and that's great, but we're not people who carry around, IVs with us. And so what do you do if you don't have that? And they give some options, but they're all kind of low evidence, which is challenging. And so when we look at all of the different options, we have a lot of options. And the top 2, the intranasal and rectal, those are ones that we can give at home, in school, at the workplace. We have generic midazolam, but now over the last few years, we've had some really great innovations with these little nasal sprays from our friends at Valtoco and Nasalam, so diazepam and midazolam. That's a lot easier to give. It's kind of just like our Afrin or epinephrine even. And then we also, for younger kids, have rectal diastat, which is the syringe up there. And the options go down to age 2 for Valtoco and diastat. Although we are giving rescue medication under the age of 2, oftentimes with diastat, I give it down to 6 months because I think it's really important, and hopefully at the end of this talk you'll feel like it's really important to have a rescue medication no matter what. But then for seizure clusters and emergencies, you want to think about something that's not as invasive to a patient, right? If they're having a cluster but they're coming to their baseline in between, you don't really want to stick something up their nose that's going to cause them to cough and maybe sputter and have a little bit of vomiting if they're aware. So we have our buccal, our cheek options, and our oral disintegrating options. And this is not a comprehensive list. It's just some of the most common ones that we can use. But really, the take-home message is have a benzodiazepine and get it in whenever your defined seizure emergency is for your child, loved one, coworker. And so we have these guidelines, and despite these guidelines that have been out since 2016, we as a medical community are really poor at treating seizure emergencies. Our treatment is often delayed. The red line on the graph on the left side of your screen is the out-of-hospital treatment time to the first benzodiazepine. And you can see, we say for convulsive seizures, that should be 5 minutes, and that's where the blue mark is. And a very low proportion are getting that medication in within the first 5 minutes. And this is for the 5 years after that new guideline came out. And when we are dosing it, also, we are giving lower doses than recommended, and that's that kind of dark blue line. And you can see for nearly all of the different medications that are given, we are dosing it low in the out-of-hospital setting and in the in-hospital setting, which is that darker pink. And with all that, you know, we're really fortunate. We're in, a lot of us are in urban areas where we have easy access to emergency services. But emergency services don't give rescue medication all the time for a variety of reasons, despite sometimes being in the care of a patient for 24 minutes. And so if you remember back to the fact that I said for convulsive seizures, 30 minutes is the time when you might start having that neuronal injury or neuronal cell death. If you are calling emergency services after a seizure has been going on for 5 to 10 minutes and then they're there, you know, you're now well into that 30-minute time frame. Here in King County, I have been recently reviewing a lot of our EMS charts for a project, and I will say we're nowhere near that 82%, but a good chunk, probably close to that, 1/4 of patients aren't receiving medications and are showing up at the hospital still seizing. So all the more important reason to have medications that you can give at home or, again, in the community. And I don't want to go really into second-line treatment, but just to say that after you give your benzodiazepine, if a seizure is still occurring and you've given 2 doses, it's really important to move on to a second-line agent, which, again, we don't have a definitive option of what the next best agent is, but we do have the time, and that should be 20 to 40 minutes. So, you know, again, we want to get something in and get a patient moved through the system so that they can stop their seizure emergency. And here in King County, we're really fortunate that we have a second-line agent available on our EMS rigs right now. We have Keppra, and it's been available since the fall of 2020. And this is just on the side showing some big studies that came out in 2019 showing that Keppra, levetiracetam, is just as effective as fosphenytoin and valproate or Depakote in all of the age groups for pediatrics, where I focus, but also for the upper bell curve is for children, for adults, and for older adults. And then ketamine is kind of, you might start hearing that talked about in the epilepsy community. There's a new trial that's coming out to evaluate its use, but it's not mainstream yet, but it's something that EMS carries as well. So we talked about rescue medications, and then thinking about how else can we help with seizure emergencies. Seizure action plans are really important. And a seizure action plan is important because I think for any patient, regardless of their age, regardless of their seizure type, I'm a big proponent. I think they should have a seizure action plan. It provides emergency contact information. It provides a description of their seizure or seizures. It lets someone know what their daily medications are, what their emergency plan is, and what their care should be after a seizure. This is the one through the Epilepsy Foundation. And you can see there's a lot of detail there. I didn't put the one that we have from Seattle Children's because it's 3 pages long. It has a ton of detail, and we sometimes modify it even for, hospital emergency plans. But ours is standardized so that it's accepted in all Washington schools and daycares. And it can include information on the ketogenic diet, on neuromodulation, like the vagus nerve stimulator, what to do for disaster planning in schools. But I really like this very simple one that one group utilized, which is kind of your stoplight. and what to do at the beginning of a seizure, if the seizure stops, if it's going on longer, providing rescue medication in yellow, and then when to call for emergency help. And I think that these simplified plans that have pictures and colors can be really helpful for our community providers to know what to do. So then how can we do better? I've already mentioned some of the ways, but thinking first about seizure action plans. Again, making sure all of our people with epilepsy have a seizure action plan. It improves knowledge of their epilepsy syndrome and seizure types. You can see here, the blue line is a questionnaire for patients who had a seizure action plan. The orange line is a questionnaire after they've had their plan for a while. And it improves their ability to know about what the epilepsy syndrome is, if they have a rescue medication, what's a seizure emergency, and do you feel comfortable administering the rescue medication. But what you can see is that that kind of confidence and knowledge goes down over time. So it's something that needs to be reviewed and not just given and say, okay, great, we did this, and now 5 years later, we've never talked about it again. We also know from some studies that having a seizure action plan can decrease people's visits to emergency departments. And so, besides in the school and daycare settings, advocating for having seizure action plans in the workplace, recognizing the value of them for all age groups. For us as clinicians, providing time in clinic to create these, they take a little bit of time, they're individualized. So even though there's a standard form, we have to think about what it is and talk about it with our patients. And for historically in adults, we haven't really used a seizure action plan because we're saying, okay, here, this is your seizure emergency, and all we have to offer you is a rectal rescue medication, which most adults weren't very happy with and didn't want. And so we weren't giving a seizure action plan because we don't want someone to know that there's this, as a clinician, we might not want them to feel like, oh, this is an emergency and I have nothing I can do for it. It's a very defeatist feeling. And so now that we have all of these wonderful non-rectal rescue medication options, I think that it's important to think about those rescue plans. And we know that seizure action plans from a different study can correlate with improved use of rescue medication, both having the correct medication, the correct timing for schools, having schools be aware of the rescue medication, having access to it, and knowing what to do if an emergency happens and the rescue medication fails. And so again, in adults, we talked about seizure action plans, but with rescue medication, historically, only about a quarter of adults have had a rescue medication. And it can take many years to get one prescribed. And so having these newer intranasal options, hopefully my adult colleagues will feel more comfortable prescribing rescue medications. And if you are an adult with epilepsy, you feel more comfortable advocating for having something for you. And it's really important to have adequate dosing. You would think there's kind of more standardized dosing in adults, but a lot of emergency medical services give lower doses because they're just afraid of respiratory depression. And so making sure, if you have one, knowing your dose, getting the right dose in, making sure that your community members and loved ones know what that is. And this is just a nice little ad from, I'm not trying to sell any medications, but I liked this quote from someone who used Valtoco, saying that with the rescue medication, they were able to go home and continue their day because they stopped their seizure a little bit easier. And so having that increased access to rescue medication. So many of our patients, there's a lot of literature out there to say that even if they have a rescue medication, they might not have access to it at school, on the bus, at their workplace. And so it's not really helpful if you only have access to it 4 hours out of the day, or just when you're sleeping. Having more frequent review of the rescue plan, we kind of talked about the fact that it's, you have that increase of knowledge and comfort at the beginning, but that trickles down over time. So having ongoing discussions in clinic and training others in use. So family members, coworkers, your school nurse, your caregivers, bus drivers on, I have a rescue medication for my patient, myself, and this is how it should be utilized. I say that because we know that there is frequent medication handling and administration errors. So even though parents may have, this is a parent study, may have already given a rescue medication in the past, they still, in simulations, have errors with handling the medication, but mostly with errors of giving the medication too fast, taking it out before it's all the way in, having a person in an incorrect position. And this is specifically for rectal and cheek buccal administration. There hasn't been good literature on the intranasal administration yet. But with that, there's some great resources on the Epilepsy Foundation about training on the proper administration of rescue medications. And it goes through the nasal medications, it goes through rectal medications, and even the oral kind of use. And I think this is really nice to let your families know about so that they can look at it and kind of review it. It's about a 6-minute video. And I think the other way that we can improve is to have more community recognition of seizures and seizure first aid. The Epilepsy Foundation does a really great free training for anyone that's interested in it. I've gone through it just because I wanted to know kind of what people are learning. But it's important, I think, because there's a lot of bystander experience seeing someone who has a seizure and feeling like you might know what to do in that situation, even if it's just making sure that they're in a safe position and knowing to call 911. And this is nice because it also helps you know what to do for someone who's ambulatory and someone who is in a wheelchair, and how to provide your first aid training. And so, additionally, I think for patients, making sure that they have a medic alert jewelry on, making sure that they have information in the health section of their phone. I tell a lot of my teenagers that, you might have a seizure and you have a behavioral arrest epilepsy. And so your seizures look very different to the common bystander than someone who's shaking. And you don't want to be mistaken for being intoxicated. You want someone to know that you're actually in a seizure emergency. And so having that information on your person can be really helpful. Training for school nurses and community members. There are specific trainings for our school nurses that they can get through foundation or through groups like the Epilepsy Foundation. And then having more simulations in clinic or in the community for kind of how to give the rescue medications. So hopefully you feel like you know that early treatment is really important, that you feel that you can advocate for anyone about having rescue medication and seizure action plans, and that you remember to review with your provider or your patient the plan and the proper administration, and trying to advocate for more community teaching and availability of these plans and rescue medications. And I realize I talked very fast. Great. Any questions that I can answer? Great. Oh.
Thank you, Lindsey. I actually have one. Do you know what the rescue options were like in the 90s and early 2000s? And I say that because that's when like my seizures were the worst. And I had like focal unaware seizures with a tonic-clonic every year or two or so on. But I had like a good 5 to 10 second aura where I kind of knew it was going to happen. And I'm just surprised, not like I'm angry at my doctor or anything, but I'm just surprised they didn't talk about like an option to,
Yeah.
cease it. So,
Yeah, the Diastat rectal diazepam option came out in the late 90s. The studies on rescue medication were all really focused on intravenous and intramuscular at that time. Dr. Novotny, I don't know if you can add in, but there weren't a lot of options for non-medical personnel, unfortunately, because you're not going to give yourself a rectal medication, right? And so even though there were those kind of oral options, I don't think that we were utilizing them in a rescue setting, and I don't know if you have any other knowledge about that.
Other than the sort of the oral disintegrating ones, some people with an aura, we would sometimes recommend those in some patients.
So
okay.
even back in the late 90s and 2000s, we were doing that. Wonderful. Yeah. And it was all off-label. It was
Yeah.
So you also had to have a provider that felt comfortable utilizing that.
Okay. Yeah, I mean, it's just super frustrating to think of like how many seizures could have been eliminated or prevented had I had something
Absolutely.
carried on me that I could have used. So,
Yeah.
Hello, and thank you for being here. I appreciated your presentation. I have a daughter who is now in her 20s. She has refractory seizures, so medications have not been helpful. Negative side effects, not the positive controls. She now has had a VNS for a year and a half. She is adamant she does not want any of the rescue meds because of how they make her feel. The only times I have given her that is if it's gone longer and she doesn't know I'm giving them, so I'll do the intranasal. Is it sufficient, or is it considered a rescue act to do the additional swipe on a VNS?
Yes, thank you for asking that question. I didn't talk about the devices at all, but yes, that's usually with our patients who have the vagus nerve stimulator. The first part of the rescue is swiping it and swiping it again. And oftentimes that can abort the seizure or the seizure cluster. And for people like your daughter, it limits the use of those really sedating benzodiazepines. So that in a lot of the rescue or seizure action plans, if someone has a vagus nerve stimulator, it should be, I'm not sharing anymore, noted on there. I know the Seattle Children's one is, and that is part of the rescue plan.
Thank you very much.
Thank you. Yeah.
So it's a little disheartening to see how little rescue therapies are being used out there.
Yeah.
And I guess my question is, what efforts are being made to educate, out in the rural communities of Washington and other places, so that, and the EMTs, I mean, how do you get more information out there? Is it through patient advocacy? Is it?
Yeah, I think, and Kevin might be able to answer some of that as well, but my experience has been trying to develop a relationship with some of the EMS groups that are local to you, so that you can go and give them talks. I am one of the providers that talks to our group about seizure emergencies. But then I think the other thing is just having more sessions that school nurses or community members can go to learn more about seizure emergencies and then advocate for their students or their family members to have the rescue medication. Unfortunately, a lot of our talks are to clinicians, right? And so it's how do you get those the word out to people who might not be in those urban settings. when I go up to Alaska, that's part of my goal up there, is to make sure all of my patients have a rescue medication, they understand it, and that I'm educating my pediatrician colleagues about their use and the rationale behind it. Kevin, I don't know if you have more information from an epilepsy foundation.
Not necessarily, but I will say what's interesting, in Oregon, there is a registry. You may have heard about it called Hero Kids. And they come to our Portland walk and they're trying to sign up families. But you can give information to this database that EMS all has that shows the list of medicine, including rescue meds. And they can pull it up and look, when they're on scene. I don't know if they carry it with them or they just know to ask about it, if they see it. But it should come to Washington. It sounds really interesting that it's available to all EMS support.
And I think that's where the seizure action plans come in handy, because they're paper, so families can have them with them. But again, you don't carry it with you when you're like going to the movie theater. And so the information, on your person about with a medical alert bracelet or jewelry of some sort or in the phone. But I think it's really the recognition of, a non-motor seizure that's still happening, and having EMS understand what seizures can look like, and that they're not just the big convulsive seizures. I think the other challenge is that benzodiazepines are a controlled substance, and so they have to talk oftentimes with their medical director and saying, like, I'm giving this, or I'm escalating, I've already given one dose, I'm giving another dose, and that delays time, and they might just say, we're 5 minutes from the hospital, we'll just wait until we get there, which is not always the best option.
Yeah, I'd like to mention, Lindsey, that I think another important opportunity is to provide primary care providers to prescribe these, because as you mentioned, intranasal is relatively new, and a lot of, whether it be pediatricians or family practitioners, are uncomfortable prescribing them. But I think we should get to a level where they should be prescribing these, and in collaboration with neurologists. But I think that's a really opportunity to get this out to the more broader community.
Yeah, and my colleagues in Alaska are very comfortable now prescribing, and we're getting more and more intranasal use. And there's, also in the rural communities, a little plug for Valtoco is that they are the preferred medication for Indian Health Services for rescue medication. So if a patient is fits under the Alaska Native or American Indian, and they have Medicaid, they can get Valtoco. So I thought that was great.
Thank you, Dr. Morgan, for a great talk and overview. I had a couple of, actually 2 questions, and then one comment about VNS. I've encountered patients or patients' families asking me, well, how often can I swipe it? Am I exhausting the VNS? Am I depleting, sort of the VNS battery by doing this? And the answer is, it's just another stimulation, slightly stronger and slightly longer than what patients get throughout the day. So you're not going to deplete your VNS when you swipe it, but it might not fire more often than the 60 seconds that it's going to be set to when it happens. So the 2 questions I had was, one of the hesitations about using these benzodiazepine rescue medications and at adequate dosing is the fear of depression, of respiratory drive. So people might not breathe adequately or stop breathing altogether. And I was just curious whether you could just elaborate on this a little bit more. It's like, what's the risk of having a respiratory complication getting the medication versus having ongoing seizure activity, right? That's one part. And then the other part is also, obviously, as a provider prescribing these a lot, it can be challenging sometimes to get adequate insurance coverage. These are very expensive medications. So can you comment on that as well?
Yes, the first part is a little bit easier to comment There have been some really great kind of retrospective studies looking at respiratory depression with rescue medication use. And historically, we've always been concerned about that, and it's really the ongoing seizure has much higher risk of respiratory depression, and when we say that, meaning decreased breathing, decreased oxygenation need for supplemental oxygen or even intubation. An ongoing seizure has a much higher risk of that than a benzodiazepine to abort the seizure. And that's even if you're giving over the 100% kind of recommended dose of a benzodiazepine. And I have data from our own patients to support that. So I really, really think that it's important to kind of dispel that ongoing historical data. I think that from a insurance side of things, I have had patients, insurance companies deny some of the newer rescue medications, and I write very strongly worded letters of appeal documenting the decreasing the use of emergency department visits, decreasing then hospital costs, and then I also I mentioned sudden unexpected death in epilepsy and the death associated with status epilepticus, and kind of put the onus on them and say, like, by denying this, you're increasing their risk of death. So, and I usually get it approved. But it takes time, and someone who is comfortable kind of wording it that way. So, other questions? I think right behind you. She's had her hand up a little bit.
One, thank you for being such a strong advocate, Mama Bear. I just want to answer to, as far as EMS in rural, I drove from over 2 hours away today to be here. I'm a parent, obviously. I said Mama Bear. And we are on towards the Hood Canal, and it's on 2 different county lines. And we're right there. And we don't have even street lights. I can't have cell phone service. I only have Starlink because that's the only option. And I just want to say I actually went to the 2 different responding EMSs and let them know about my child and his needs, and they asked for a 1-pager, and for me just to update that information to them so that they can have the basic needs and understanding of what the situation is. So
That's great.
just expressing that to maybe for other parents to do that. I know that can be a little rough and time consuming, but if you just kind of chomp at the bit a bit more, you'll get that information in the right person. I also even found out that they have snow cats, so whenever the trees fall down, that they can still get to us. So I also recommend, having your own little emergency pack. We have the name escapes me now, but the own little breathe bag as well. So for those rescue medications that need to happen. With all of that being said, where do I find the child version with the green, yellow, red on the SAP?
Yeah, so that is through a study in Michigan, and I think it's available for download, but I can provide you the reference there. And this can be, you can use it for adults or pediatrics, and it should be the same for either. Yeah, absolutely. Of course.
Thanks. So, are there reasons other than insurance that rectal medication would be prescribed?
I think not knowing the different options is one. Some under the age of 2, oftentimes that is what we are prescribing just from a dosing standpoint. And then sometimes we speak up until recently with the already kind of pre-packaged, ready to go nasal option. because Diastat is already packaged, ready to go, and easy to give, oftentimes families for children who may have some neurologic delays might opt to have that because they want something that they don't have to put together with the generic intranasal midazolam and just be able to give it in quickly, and they feel that it is not as socially unacceptable in their child as maybe someone who is a more neurotypical teenager. So that's when I find myself prescribing it.
Okay. And then do you have any tips about how school nurses can help families access the nasal or the other forms?
I think just, when you get your seizure action plan for the child, and you're reviewing it, if you see a rescue medication in someone that you think maybe could be altered, I think just having that conversation with the family and saying, oh, I'm aware of these other options. Are you aware of them? Have you talked to your neurologist about them? There may be a reason that the neurologist prescribed what they did. And so bringing it back to the family to talk with their neurologist about those options. And you may find out that they're like, oh, I had no idea, because I don't know that we all do the best that we can do.
And I'm curious about the comment about primary care prescribing this, because I've only seen neurologists kind of providing care for the kids' seizures. So is kind of having conjunction with primary care providers a newer thing, or?
No, it is something that we are advocating more and more for, because the access to neurologists, especially in more rural areas, is very low. And so oftentimes our primary care providers will provide rescue medication for our patients or our children who have febrile seizures, because they don't all see a neurologist, but they might still have a seizure emergency from that. And then additionally, sometimes we'll talk with the primary care provider before we're able to see the patient in clinic, and we say, oh yeah, like they presented to the emergency department, this is clearly a seizure, please prescribe them a rescue medication, and we might talk them through that until we're able to see them and assume that care.
Great. And last question. So after seizure rescue medication has been administered, typically you need to call 911 and activate that. And sometimes families are like, yeah, I don't want to do that.
Yeah.
And it sounds like, I guess, can you speak to that whole topic of calling 911 or not?
Sure. I think everyone is a little bit different. Most of our practice at Seattle Children's is to say the first time you use a rescue medication, call 911 to make sure that the seizure has stopped. Because again, seizures can look more subtle after you've given a rescue medication, or they just might not stop at all. And then to make sure that the breathing and the sedation level is okay. Because if we have never given it, we don't know how they're going to respond to it. And there are complications, even though we're saying that it's less than an ongoing seizure. And then many of us will, after that, say, wow, you got the rescue medication, you did okay with it, it stopped your seizure, and if you use it again, it's up to your feeling. If you feel like your child is coming back to baseline, that they haven't, that the seizure has stopped, you don't have to call EMS services. And so I think that's kind of usually our practice. For schools, oftentimes it just says, call 911 if, and for Seattle Children's seizure plan, it's, if the seizure's ongoing or if it meets these criteria. But it will have, call the parent first as well. So.
Thank you.
Yeah, of course. Thanks. Kevin, I don't know what the timing is.